Welcome to UCSD Department of Medicine Grand Rounds. We apologize for the technical difficulties that seem sometimes insurmountable. It's a tradition of the UCSD Department of Medicine to have our chief medical residents present at Department of Medicine Grand Rounds. The chief residents hold an important role in the department, advocating for positive change on behalf of our program. They know our program better than anyone else could, having experienced every moment of it and dedicating an extra year of their lives to helping us to improve and support the program. We're deeply grateful for their service. It's my pleasure today to introduce two of our chief residents who will be presenting. And first, I'm going to introduce Dr. David Timmer. Dr. Timmer earned his Bachelor of Science in Biology with minors in chemistry, mathematics, microbiology, and immunology from the University of Miami. He then earned his MD degree from Morehouse School of Medicine, where he received the Basic Science Academic Award in Medical Education and the Ambulatory Adult Medicine Award, and graduated cum laude. We were fortunate to recruit him to our internal medicine residency at UCSD, where he has excelled in patient care and leadership. During his residency, Dr. Timmer pursued research in cardiology under the mentorship of Dr. Cruz Rodriguez, studying outcomes in orthotopic heart transplant amongst patients with a history of methamphetamine use, as well as statin therapy and lipid outcomes in heart transplant recipients under the mentorship of Dr. Hong. He presented his research at international conferences, including the International Society of Heart and Lung Transplantation and Heart Failure. Due to his excellence in patient care leadership and professionalism, Dr. Timmer was selected to serve as a chief medical resident. This year, his duties have included leading our Advancing Health Equity, Advocacy, and Diversity curricular thread and our journal club. He's also shepherded our residents in solidarity with Emerging Leaders Arise Near Peer Mentorship Program. Next year, starting in July, Dr. Timmer will be a cardiology fellow here at UCSD, and he will be, yay! He will be speaking today on GLP-1 receptor agonists for cardiovascular disease, not your ordinary weight loss drug. Dr. Timmer, take it away.
Thanks for the introduction, Dr. Jassel. So I'll be, as Dr. Jassel stated, I'm gonna talk about the GLP-1s once I figure it out perfect, and their role in cardiovascular disease. I think we all kind of know, or even people who are not in medicine know this medication at this point as a weight loss drug. So we're gonna talk about this. First, I have no disclosures, and I'm gonna start with an outline of like the conversation today. We'll talk about the GLPs in general as a drug, then move on to their role in diabetes and cardiovascular health, cardiovascular diseases. Then we'll talk about it like with isolated cardiovascular disease, basically just for cardiology on its own. So why does that matter? Why are we gonna talk about the heart here? And just kind of like as a reminder, cardiovascular disease is still the #1 killer in the States and also worldwide. So that's kind of like an important reason why this is being looked at, in particular with diabetes, because the risk is even higher with this. Like I think even with like your ASCVD score, like once you have diabetes above a certain age, you automatically qualify for a statin. That's just like another thing, like pretty well known in the field of medicine. So I'll introduce you to like a timeline to the GLP-1s. And we'll start in 2005, where the GLPs were approved for type 2 diabetes management. And so what is the GLP, what's GLP-1 essentially? What is that like molecule? So we have that endogenously in our system. It's made mostly in the gut, the small intestine. So that's where most of it is made. Some of it is made in the pancreas and some of the cells there. And it can also be found in the brain. So what does it do? Like it enhances glucose-dependent insulin secretion. So inhibits glucagon release, slows gastric emptying. So also reduces appetite. So of course, like because of like the essentially like glucose-dependent insulin secretion and all the other factors that it provides, it was looked at by the endocrinologist. Such a great drug for treating diabetes, right? Another weapon in our arsenal. So there's a one problem though with it is that the native GLP-1 like it's an incretin essentially, and it doesn't stay long in the body. So I think in the order of minutes is what I was reading about. And it's degraded by an enzyme called dipeptidopeptidase 4, DPP4, and also there's renal clearance there as well. So it kind of limits the therapeutic use of that medication. So this is like the diabetes kind of like effects that we were talking about, why it's looked at by the endocrinologist. So then I'll ask you a question. Anyone know this guy here? The Gila monster, or is it a monster? I actually found this on the San Diego Zoo website. So is it a monster? So I'm gonna try to convince you that it's not, or we should be thankful for this little creature. So someone by the name of John Ang marked like basically a significant breakthrough. Isolated the venom or the saliva, depending on where you read, of this guy here, and isolated a peptide that's an analog of the GLP-1, but it's more stable and basically like lasts in the orders of hours and is able to kind of do that job for us. And that's kind of like how we ended up in 2000 with that drug that got approved for type 2 diabetes in 2005. So going further into the timeline, if you guys remember the TZDs, specifically there was rosiglitazone. There was a meta-analysis for that medication that suggested negative cardiovascular outcomes, particularly water retention, heart failure exacerbations. So that was like a big issue. So this medication that helps you with diabetes but causing like water retention, that'll make your cardiologist kind of like scream and terror. And so that caused an issue. And by the next year, the GLP-1s already established as a medication for diabetes, and the ADA guidelines, it became like a tier 2 medication. Your metformin, like sulfonylureas were tier 1 first line for diabetes. And then at the same time, the FDA was like, okay, because of the TZD issue, we got to look into the new medications as they're coming in. So now we're mandating that like the trials that are being pursued have to look into cardiovascular outcomes for those medications. So so basically now you got to do this rigorous kind of like cardiovascular outcome trials. So someone for the GLP-1s like came up with this trial, like the LEADER trial, that like happened in 2016, and that was a landmark trial really. Like I think the appropriately named like the LEADER trial. So it was a randomized double-blind placebo-controlled trial. It evaluated the outcomes of liraglutide specifically. So essentially randomized patients to receive like 1.8 milligrams daily or the placebo, in addition to standard of care, and followed them for 3.8 years. So the primary outcome was essentially MACE, like major adverse cardiovascular events. And that's like, we're talking about cardiovascular death, non-fatal MI, non-fatal stroke. And the result of that was a 13% risk reduction in MACE in type 2 diabetics. So like we're trying to make sure this medication was safe, right? So now we're seeing, okay, there's like actually like significant risk reduction going on here. So it actually is beneficial for patients. So now you're starting to think about your patient we're living with diabetes and who has ASCVD risks, and then this medication is like shown to kind of like benefit the patients at this point. So interestingly, a few months after, same first author just kind of like comes out with another paper like Sustain 6, so looking at semaglutide and cardiovascular outcomes. So at that time, semaglutide itself is not yet approved by the FDA for type 2 diabetes. So again, like pivotal, like randomized double-blind placebo-controlled trial assessing like a cardiovascular safety of that medication. So we're randomizing patients to receive now, we're talking about different doses, higher doses of 0.5 milligram or 1 milligram once weekly of semaglutide against placebo. And we're following them through like over about 2 years. And again, the primary endpoint of that trial was that major adverse cardiovascular events, like the MACE, the famous MACE. So we're seeing again like a 26% MACE risk reduction with that same population, patients living with diabetes and ASCVD risk, and we're seeing there's like a significant risk reduction. So now we're establishing this maybe as like not only just like the liraglutide that was done with the LEADER trial, but also semaglutide. So now we're seeing kind of a class effect. So that's solidifying the GLP-1s as not only safe, but also beneficial for patients with those ASCVD risk or like in terms of cardiovascular outcomes. So going back to that timeline, like in 2018, after these trials happened, so what the way it was kind of worded is metformin is still your first line, right? In addition to your other kind of like first line, like diet and all that kind of stuff. And if your A1C is not at goal at this point, if the A1C is not at goal, then you kind of like risk stratify your patient. You're kind of like looking at the profile of your patient in front of you. If it's like mostly ASCVD risk, then you're gonna add that GLP-1 to the regimen at this point. So a few years later, I don't know if you guys followed that, but in 2023, the ACC/AHA came out with an update to the heart failure guidelines, and now we're establishing its cousin, the SGLT2 inhibitors, as like a class 1 indication for heart failure with reduced ejection fraction. And that means like you have to put the patients on that medication essentially. It's now one of the 4 pillars for HFrEF. At the same time, the SGLT2 made its way into the care of HFpEF, patients living with HFpEF as well. So now its cousin is like gaining popularity essentially in the heart failure and cardiovascular world. So that kind of like led to the next set of guidelines with the ADA basically putting the GLP-1s in the forefront now. So essentially what the wording is now, we're no longer seeing metformin first line. Is you look at your patient living with diabetes and risk stratify the patient based on like what they have. If it's like major ASCVD kind of risk, then we're talking like GLP-1s as first line for type 2 diabetes now. In addition to like the other components like weight loss benefits, and there's like tons of studies that were done like for it as well. But so the question now that somebody asked is, okay, great medication for diabetes. What about patients not living with diabetes who have ASCVD risk, also like elevated BMI? So what do we do with this information? So another smart person like came out with this trial, the SELECT trial. I'm not sure how many of you have heard about this one. Came out like October, November of like 2023, and I remember being on the cardiology consult service here at the VA, and my fellow and my attending were raving about this because they talked about it at the ACC kind of conference, and basically this was looking at semaglutide and cardiovascular outcomes, and the difference here is that it's looking at patients without diabetes. So remember the LEADER trial before, like, and then the SUSTAIN 6 was in patients living with diabetes. And now we're randomizing patients receiving semaglutide 2.4 milligrams. You ramp up to 2.4 once weekly. Adults over the age of 45 years old with BMI over 27. And then we're looking at that MACE outcome again. And now what are we seeing? 20% MACE risk reduction in semaglutide in patients without diabetes. So that was also like groundbreaking because that was like the first one that showed this kind of benefit outside of like diabetes. So that was like a pretty good trial, landmark trial that made people kind of talk a lot about its role like in cardiovascular health. And then, so the next piece of evidence that I'm going to talk about was technically a few months before, but just so my pun can work, they took it a step further, pun intended. So there was the STEP HFpEF trial. So there have been STEP trials before, and at this point it's STEP HFpEF. And around the same time also, so now we're looking at patients with heart failure with preserved EF and obesity and looking at the role of that GLP-1, specifically semaglutide. So this one was also international multi-center double-blind placebo-controlled trial. You have patients with HFpEF with BMIs of 30 and above to receive semaglutide 2.4 once weekly versus placebo. And the primary endpoint, it was kind of like a dual primary endpoint. We have the result of a questionnaire called the Kansas City Cardiomyopathy Questionnaire clinical summary. So what is this? It's basically a questionnaire looking at like their functional status with emphasis on physical limitation and also like the symptom frequency. Basically, that really looks at like how they're feeling, aka like their volume status, shortness of breath, all that kind of stuff. The higher number, the better. The lower number, the worse off they are. And then also the other component was weight for the patient. So this is the results. You can see how nicely these curves separated. So we have like an improved quality of life and in weight reduction with semaglutide without type 2 diabetes. And contrast that with the scare that happens with the TZDs back in 2007 with that meta-analysis that showed rosiglitazone like showing like increase with like water retention, edema, and all that stuff. So that wasn't good for heart failure, but this medication seems like it is good with heart failure. So we're kind of like now in a world where we're seeing like the semaglutide, like diabetes medication outside of diabetes benefiting cardiologists and their patients. So why does it work like that? So I think like going back to this initial slide like would be a good way to kind of explain this. We don't have like the exact mechanism of how, like it's not necessarily strictly a diuretic effect or something like that, but it's more like a pleiotropic effect. So there are receptors on the heart for GLP-1, and maybe it could be a direct effect on the heart with cardioprotection, increased cardiac output or something like that. That's possible, but also let's not forget about other effects that it has, like with the immune system decreasing inflammation. That's good for like the coronaries. We love that, love to see that stable plaque with like lipid modulation. And then, yeah, cardioprotection in general, like there's multiple mechanisms, and also losing weight, because we know that this medication helps with losing weight. Maybe that's decreased afterload for the heart to work with. So many things kind of like causing or helping the heart do its thing, right? Pumping and having thin coronaries. So, so this is like just an emphasis that it's beyond like glucose toxicity, beyond glucose like control. I do want to add, like I actually forgot to mention the ADA guidelines before when the GLP-1s were at the forefront. At that point, we're seeing GLP-1s first line, but also GLP-1 no matter what the A1C is, like because the data was so good. Like even if like you have a patient on metformin, A1C is fine, but they have like these characteristics at the GLP-1 because of the benefits. This is like without diabetes at all. Like, and so I wanted to ask the audience a question at this point, right? With this medication that we have, how many of you have patients coming into clinic asking for a statin? Asking, doc, I want atorvastatin, I want rosuvastatin. No, and that's what I thought. Like it hasn't happened. Well, actually, this happened to me once, but I had to counsel them before. And how many of you have patients coming in and asking for one of the GLP-1s? That's like almost everyone. So everyone wants that medication, right? And that kind of is great. It's awesome because it's actually a good medication, and it raises like concerns for like equity with the distribution of the medication. So basically supply and demand. Like let's assume that you get the medication approved for your patient. You can get it to their hands, right? But like you get past the insurance company, you get it approved. So there's a supply and demand issue, like a lot of like demand for it, but not a lot of supply for it. And now you have people kind of like thinking about what's the best way to get that medication in the hands of your patients. I had patients who had the medication and then stopped having it because they ran out, the pharmacy ran out. So there's no supply, but like another patient knows where to get that medication. So that's kind of an interesting phenomenon. And in this like article, it's kind of like a piece talking about fair allocation. The author kind of like goes over maybe risk stratifying patients in tiers. Like maybe the first one is severe obesity with bad diabetes, then severe, like maybe less severe obesity and less severe diabetes, and then like the cardiovascular things, and then no preference for cosmetic reasons for GLP-1s. It's kind of interesting because the people living with diabetes already claim that medication for themselves. So that's how it came out first, right? So now we're saying like cosmetic reasons, like no, let's not do that. And so I don't know what the answer is. Like I can see why we're prioritizing some people, and within each class they kind of prioritize younger people who have much more to kind of live for. But it's kind of an interesting topic. We're not going to delve too much into that. But my take-home message is here from my talk is just a reminder that cardiovascular diseases still remains like the #1 killer in the U.S. and worldwide. Higher risk in people living with type 2 diabetes. And then how like the cardiovascular and endocrine system are actually closely intertwined. And then hopefully like I've convinced you that GLP-1 agonists are not only a diabetes medication, but it is a cardiac med. And I know that like even now, I think the guidelines, or at least the FDA approved the GLP-1s for renal protection at this point, right? So just renal protection has been done. It hasn't been, I don't think it's been approved yet for like just cardio protection, and it's not in the guidelines yet. But I think like in the horizon, what we're gonna see, I think we're gonna incorporate that in like the ACC or AHA guidelines for GLP-1s. They've already put it in for people living with diabetes with ASCVD risk. But what I'm saying is just for cardiovascular kind of benefits, just cardio protection, as just a cardiac med, that's probably going to make its way. And yeah, like the chest pain guidelines or something like that, or heart failure guidelines with HFpEF in particular. And that's where I'm going to end. But before that, just a special thanks to Dr. Jasso, Dr. Santos, and Dr. Pam Taub for helping me with this talk. And I'll take your questions at this point.
Thank you for that riveting presentation, Dr. Timmer. We're so grateful to you. This presentation is open for questions from the live audience. You guys get first dibs. Are there any online questions?
Yeah. It's your email. Curious, there was a shortage of the GLP-1s almost common last year. Seems like some of that has loosened up a little bit. There's like compound pharmacies that kind of stepping in for a lot of these like companies now kind of have GLP-1s like you get their compounds, not necessarily direct from the drug manufacturers. Makes me think like if we do get the guideline recommendations for HFpEF, kind of like how the market would respond to that, how it's going to be applied, like how much heart failure reducing that patient, how that's expected to go.
So the question was about kind of like when it makes its way to the guidelines, how are we going to get the insurance companies to approve things, right? And then also supply and demand. So I don't have the answer to that, but even with the guidelines, I don't anticipate that it's gonna like maybe it will, but like the SGLT2s when they came in, just like came in running. Like for HFrEF, like it made its way straight up like to like class 1, right? So I don't know if it's gonna be like a class 1, i.e. like something you have to do for your patient, but like something that has like moderate or like semi-moderate recommendations. So I don't know if they're still gonna say try this before this. And as far as like getting it in their hands, like I don't know the answer to that, unfortunately.
Yeah, I think.
Yes.
There are few. I mean, there's some people that say that there are many, but I think there are few negative effects of this kind of drug into people.
Yes.
One of the effects is the loss of muscle mass.
Yeah.
Especially when they stop taking it.
Yes.
Do you think if any of those mechanisms affecting skeletal muscle can be affecting cardiac muscle as well?
Oh, that's an interesting question. So I think we're talking about sarcopenia, like essentially happening if you even while on the GLPs as you're losing weight. And then I remember reading and they were like beware of sarcopenia. So I think something not to forget is like you still need to like counsel your patient on like the other things like weight management, like exercising, so you can keep that muscle mass up, because otherwise you're probably going to lose that. So as far as like cardiac muscle, I haven't read anything about that, but maybe just because it's a different type of muscle, I'm not sure if like it would affect the heart. But so far we're seeing like the benefits of it, and just like I'm not sure what would happen. For example, I know for weight, if you stop taking it, you gain back some weight. Are you gonna lose back some cardiac function? I'm not sure about the answer to that. But I think it's just a reminder, continuing like the baseline things for like the skeletal muscles, like continue weight exercises, going to the gym, and in addition to this, kind of like prevent that sarcopenia risk in the GLP-1s. Thank you. Great question.
Okay, great. Thank you so much, Dr. Timmer. Next, it's my pleasure to introduce our next chief resident, Dr. Maedha Begur. Dr. Begur was admitted to the prestigious UC San Diego Medical Scholar Program, earning her BS in biochemistry and cell biology with a concentration in political science at UCSD. She then earned her MD degree from UCSD School of Medicine, where she was awarded the Medical Student Training in Aging Research Grant. We were fortunate to recruit her to our internal medicine residency at UCSD, where she has excelled in patient care and leadership. As a resident, Dr. Begur participated in the global health pathway and pursued research investigating cardiovascular outcomes in COVID-19, presenting at the American College of Cardiology meeting and publishing in Clinical Infectious Diseases. She also pursued research under the mentorship of Dr. Cruz Rodriguez, studying conduction disorders following donation after circulatory death, heart transplantation, and presented this work at the International Society of Heart and Lung Transplantation. Due to her excellence in patient care leadership and professionalism, Dr. Begur was selected to serve as a chief medical resident, and this year her duties have included leading our global health pathway and our ultrasound curriculum. Dr. Begur will also be a cardiology fellow at UCSD in July. Yay. Today, Dr. Begur will be speaking on Drop the Beat, Conduction Disorders After Donation After Circulatory Death, Orthotopic Heart Transplantation. Thank you, Dr. Begur.
Thank you, Dr. Bassel. Yay. Thank you, Dr. Bassel. So excited to continue to bother Dr. Timmer for the next 3 years, but I'd love to talk to you about our work looking at conduction disorders after DCD or donation after circulatory death, heart transplantation. If you're wondering what that is, stay tuned. I have no disclosures to report. Not making any money. As some background, I think we all know this, but heart failure affects over 6 million people in the United States. And not only does this pose an emotional, a physical burden to our patients, but this does pose a significant financial burden to our healthcare system. By 2030, we expect this cost associated to taking care of patients with heart failure to exceed $70 billion, and this accounts for interventions for heart failure, hospitalizations, days missed out from work, disability, kind of the whole picture. And not only is this going, as a problem now, but this is going to continue to rise as our population gets older, as we see more patients with coronary artery disease and other comorbidities that lead to heart failure. I hope we've all seen this chart before, but I think the current paradigm of how we treat patients with heart failure is 1, looking at the risk factors for developing heart failure, 2, the evidence of structural heart disease, and 3, their symptoms. And for this talk, we're honing in on our class 4, like New York class 4 patients who have symptoms refractory to our usual GDMT or guideline-directed medical therapy, like putting them on ACE inhibitors, etc. And once they have symptoms refractory to that treatment, addressing the underlying cause, revascularizing them, we have very few options. As you can see here, one of our main options is hospice. Otherwise, we have like chronic home inotropes. And for the lucky few, we have things like mechanical circulatory support, including LVADs, which are left ventricular assist devices, as well as transplantation.
Dr. Begur, I'm sorry.
Oh yeah,
Try
please.
to stay at the podium.
Oh, I'm so
the Zoom
sorry.
audience can
Okay.
Continue to see you.
Apologies, I can't.
interrupting.
I will stay.
Continue.
I will stay over here. Okay, great. Thank you. So the question really becomes, why don't we just transplant everybody, right? We know that transplantation works. It has a great outcome. The median survival is over 12 years. And a study in 2011 showed us that while 20,000 patients may benefit from transplantation, that year we only transplanted less than 2,000 patients, so less than 10%. And the question was why? And we realized that the possible beneficiaries, the number of possible beneficiaries greatly outweighed the number of available donors, especially in our country where people aren't like listed to transplant automatically. And so the question becomes, okay, so if we can't transplant them, what else can we do? And I think LVADs are an exciting new technology, left ventricular assist devices, and people were very excited about this premise of like, okay, we don't have the availability to transplant everyone, can we do something else? And I think the early outcomes were rather favorable. This study by Kokonides and team showed, it was a meta-analysis of I think 7 studies looking at the 1-year morbidity for patients transplanted versus LVAD. And as you can see here, there was no significant difference at 1 year between patients who received LVADs as a bridge to transplant and heart transplant at 1 year. And additionally, they showed that patients who had LVADs as destination therapy versus transplant had no difference in morbidity at 1 year. And so this is pretty promising, right? We're like, okay, great, we can transplant patients or we can LVAD them and it has the same effect. However, I think, if you just look at the mechanics of an LVAD, you're putting a continuous pump in a patient. It has as you can see here, it has a percutaneous lead that comes out of their skin, connects to a battery and a control system. And then you have a pump going into somebody's heart with a cannula that leads to the aorta. And as you can imagine, this leads to significant outcomes, right? And we find that after LVAD implantation, within the first 6 months, you're at higher risk of stroke, infection, RV failure, and bleeding. So this is not an intervention without risk. And also, I think additionally, it's important to look at the long-term outcomes after LVAD. We said that heart transplant has a median survival of over 12 years. LVAD, as you can see here in this study, no matter what the indication was for implantation, at 5 years, your median survival is only 40 to 50%. So while it's a great alternative, it does not make up for the difference in benefit from heart transplantation. Yeah, median survival greater than 12 years. So this was really like the push. This really brought up the push to expand the donor pool. What is our acceptable standard for a donor, and how can we get patients to receive heart transplant? I think some notable pushes are including patients who've had hepatitis C, and including recent research has shown like patients with HIV, donor to donor, and then also patients who have COVID, can we use them as donors as well? But I think the most promising population of donor hearts is actually donation after circulatory death. I realize this is like a weird concept, right? Like the heart has arrested, and normally we use patients, or we have patients who've donated their hearts after a severe, brain injury. We declare them brain death, and then we kind of pronounce them, and then they kind of go along this transplantation donation pathway. So just to walk you through it, so typically a donor will have some sort of like severe irreversible brain injury. We declare them brain death per like legal terms. They have a complete loss of brain function. Their heart though is totally okay. We pronounce this patient, legally brain dead, and then we proceed along the donation pathway. But now we have this new pathway where a patient will have some sort of severe irreversible brain injury, but their heart still works. Their heart is fine, but they have some other sort of incurable terminal illness, let's just say like a respiratory disorder or multi-organ failure, but their heart is still okay. We as a medical team will then say, this patient is likely to not recover. We declare them unable to recover. We declare them unable to, we basically declare them dead, and then we would withdraw life support. And then this heart, the donor heart, then undergoes an episode of hypoxia as we would declare, withdraw life support, and then arrests. And then once we pronounce the patient, we give them the time, normally like 2 to 5 minutes, of being able to recover on their own. And once that patient passes, we then pronounce them dead, and then at that point, we declare this heart acceptable for donation. So it's a little bit, I think the uptake of this is obviously understandably a little hesitant because, what is that period, between 2 to 5 minutes to give that time to the patient to recover. But I think it's a good opportunity for us to increase our donor supply. So once that point comes where you withdraw that life support, there are two options that we have to allow perfusion to the heart. So one is in situ, so the normothermic regional support, which is basically like ECMO. We're perfusing the heart in the body of the patient who's passed, versus heart in a box, which is direct procurement perfusion. So you take the heart out and you place it in this perfusion system, which is like, I don't know if you guys have watched Grey's Anatomy about like heart in a box. You're like basically perfusing this heart outside the body. And this donation after circulatory death is aimed to increase the donor pool by at least 30%. It hopefully will decrease waitlist time and mortality and increase the like indications for transplant as well as the transplant volume. And just really to stress what is happening to the donor heart once it is, accepted for donation. For DPP, which is like heart in a box, once you withdraw the care, then you've declared the patient once they are unable to be resuscitated on their own. And then you have some functional warm ischemic time, the FWIT, and then cold ischemic time. So the whole time this heart is being taken is ischemic. And then you have placed it in the heart in the box, the OCS machine. And then it again experiences ischemic time once you're like taking it out of the box, putting it into the patient, and then warm ischemic time once we're putting it in the patient and the blood is finally flowing. And then same with the like ECMO version, the normothermic regional perfusion. It has functional warm ischemic time when the patient is passing, and then again in the body, and then again during transport, and then again once we're putting it inside the patient. So you can see here that this heart has undergone a significant amount of ischemic time prior to getting into the recipient's body. And so this brings a lot of concerns, right? Like, okay, normally we're able to take a heart from a person who, his brain's not working, but their heart's working. It's this, they're perfusing their heart. There's not that much ischemic time, versus now you're taking this heart out of this person's body. You're exposing them to all this ischemic time, cold and warm. And I think all of us are concerned, like, does this affect outcomes, right? Because your heart, obviously we know ischemia is bad. And so Siddiqui and all actually studied this because I think this is a huge concern, compared to liver and kidney. And they found that 1 year survival was comparable, severe primary graft dysfunction was comparable, 1 year rejection rates were comparable, as well as cardiac allograft vasculopathy, which is a fancy way of saying accelerated inflammatory coronary artery disease. And then also readmission rates were comparable. So we're finding that early results show that DCD heart transplants are comparable to DBD, or donation after brain death, which I think is good. And then we're also seeing that increased transplantation rate because of these data that show that it's pretty comparable. My specific area of interest is electrical outcomes after heart transplantation. We know that arrhythmias after heart transplantation are common and oftentimes expected, but some are expected and some are worrisome of graft dysfunction. We have like AFib, sinus node dysfunction, higher resting heart rate, etc. Sinus node dysfunction is extremely common after heart transplantation. If you think about it, you're literally cutting the electrical signaling to the heart, taking it out and putting it in someone else, and that obviously takes some time to regrow. And so I don't know if any of you have taken care of patients with heart transplantation, but they always have like a higher resting heart rate because they lack the vagal tone to their heart. This is very common and very expected. So peri-op, post-op, patients end up with temporary pacing wires, and we give them medications like theophylline, isoproterenol to speed up their heart rate, to kind of kick their sinus node into action. But some patients, I think like 10 to 20%, do require a pacemaker because their sinus node never kicks back in. And we found that biatrial anastomosis, rather than bicaval, which we'll go over, is a huge risk factor, as well as graft ischemic time. We know that conduction tissue is very sensitive to ischemia, and you can expect that like the ischemic time from taking a heart out of someone to putting it back in, does pose a risk. And we found that greater than 260 minutes is that kind of marker. And just to explain the biatrial versus bicaval technique, we used to do biatrial heart transplantations, which means we straight up cut the atria in half. And as you can imagine, your sinus node to AV node, that whole like railroad is sitting there. So you can imagine that most patients who had a biatrial anastomosis developed some sort of conduction abnormality, and here at UCSD we do a bicable technique which splits the IVC in half and avoids avoids cutting into the right atrium, so you would expect that to have less of a conduction disorder. And then I think just to touch on like the expected conduction changes after transplant, if you can imagine, you're cutting all the vagal input into that transplanted heart, so you don't get that vagal response with coughing, exercise, etc. So patients with heart transplantation will have like a natural heart rate, normally like in the hundreds to 110s, as well as they have a delayed chronotropic response to exercise. We see this a lot in clinic where a patient's like, yeah, I went on a run and my heart rate was smacked out 110. And you're like, that's a little weird because you're like you're really working out, and they find that they're really fatigued after heart transplantation. So it takes some time for those nerves to kind of reinnervate and kind of get in there. So the question we had is, given that DCD hearts are literally exposed to more ischemic time than DBD hearts, does this increase the incidence of persistent conduction disorders and require more pacemaker implantation than DBD hearts? And so we did a retrospective analysis of all the hearts transplanted here at UCSD between 2020 and 2022. We followed them until their most recent encounter in epic or death. And then just of note, we looked at prolonged epicardial pacing. And so most patients after open heart surgery, they'll end up with 2 pacing wires in their LV and RV. And we look at and see if they required pacing that day. So we defined prolonged epicardial pacing as 5 or more days of epicardial pacing. We also looked at moderate primary graft dysfunction, which is more of like a hemodynamic definition of like if their heart's pumping or not. And then severe graft dysfunction was defined as need for left or biventricular mechanical support. So our average, we had like 226 transplants over the 2 years we looked at. 72 of them were DCD transplants. The average age was like 55. We had about 20% of those patients being women. Overall, the demographic data between our DCD and DBD groups were very similar. In addition, their chronic illnesses were similar between the DCD and DBD groups. However, we looked at like their pre-transplant kind of risk factors, and we found that the DBD group they were more likely to require inotropes or MCS, mechanical circulatory support, prior to transplant. And then we mainly looked at the electrical outcomes after DBD and DCD heart transplant. Our main question was to see, does the increased ischemic time that they experienced during DCD heart transplantation, does that correlate to any outcomes? And we thankfully found there was no significant difference in epicardial pacing, prolonged epicardial pacing more than 5 days, or pacemaker implantation. So we do note that the overall rate of implantation was very low in our cohort. We only had 3 patients who required pacemaker implantation. 2 of them were DBD, 1 was DCD, and that was not statistically significant. And then we also looked at the inpatient morbidity and mortality between our DBD and DCD heart transplant recipients, and we found that majority of them were similar, they both experienced the same amount of primary graft dysfunction, but we did note that our DBD group did experience more in-hospital death that was statistically significant. And then we wanted to look at, for those patients who required prolonged epicardial pacing, so more than 5 days of being attached to those 10 pacing wires, were there any risk factors that we could identify? And the only one that came statistically positive was having a history of VT or VFib. But on multivariable linear regression, we found that once adjusted for amiodarone exposure, this was not a true risk factor. And amiodarone exposure was interestingly related to having a lesser likelihood of requiring prolonged epicardial pacing, which is a little different than what we were expecting. Yeah, and then we also looked at, for those patients who did require prolonged epicardial pacing, was there any significant outcome in terms of their inpatient morbidity and mortality? And we found that other than an extended ICU length of stay, which was for those who required prolonged epicardial pacing, which they required 13.8 days versus 8.7, there was no other significant outcomes, which is the reason we asked that is because oftentimes arrhythmias, sinus node dysfunction can be a sign of primary graft dysfunction, which is the feared complication after heart transplantation. But other than ICU length of stay, that was not a concern. So I think overall we showed that the overall incidence of conduction abnormalities and pacemaker implantation after transplantation, either with DBD or DCD donors, was similar, which I think is a good thing, and it adds to the ever-growing data that DCD is a safe and viable alternative. And then we also found that while prolonged epicardial pacing was associated with a longer ICU length of stay, in both groups, it didn't have any significant outcomes in terms of like graft dysfunction or mortality, which I think is reassuring as well. We do note that the slightly higher in-hospital death in the DBD heart transplant group may be reflective of their higher risk pre-op. We do know that most of them were, a higher number of them were on like inotropes or MCS pre-op. And then interestingly found that amiodarone exposure was less likely to have prolonged epicardial pacing. I'm at a loss for what the mechanism might be for that, but prior studies have shown that actually amiodarone exposure pre-op leads to worse outcomes with like more primary graft dysfunction, higher 30-day mortality. So that's something that we need to look more into. I think it's interesting that our study had such a low rate of pacemaker implantation. Prior studies have reported up to 10 to 20% of patients who received a heart transplant required pacemaker implantation. I wonder if that's due to our surgeons' expertise, less ischemic time, use of the bicable anastomotic technique that contributes to that. And then another thing that I think is interesting and would be wonderful to look into is seeing how much of this is reversible. Most of these pacemakers are put in for sinus node dysfunction, and studies have shown that at 6 months, the pacing requirement for patients who have the indication of sinus node dysfunction decreases. So I wonder if these patients are truly pacemaker dependent at 6 months post-transplant. So I think that things that would be really interesting to talk about or to look into are like longer term conduction abnormalities, and then having a bigger population of patients who required pacemakers, because we don't currently have the power to figure out who, like the predictors for patients who require pacemaker implantation. Yeah, that's all I have. Thank you to Dr. Cruz for helping me with the study, and Dr. Jasper for reviewing it, and Dr. Iyer for helping with the data collection. But yeah, thanks.
Thank you for that fascinating presentation, Dr. Begur. Dr. Begur's presentation is open for questions from the in-person audience.
So basically, thank you for your talk.
Thank you, Dr. Maedha.
From the arrhythmia standpoint, it would seem like, at least here, they perform through the bicameral technique. I guess, would there be advantages from other perspectives to doing the biatrial technique? Because I guess here it's like, ubiquitous, that's just the technique that's used. So I was just wondering,
Just briefly repeat the question.
Oh yeah, so the question is there advantages to biatrial technique versus bicable?
Assumingly everybody here gets bicable, and
Yeah.
there's a benefit from that.
I'm not a surgeon,
Okay.
but from my understanding, it seems like biatrial is more technically feasible, whereas bicable requires more time intra-op. However, most major institutions that are heart transplant centers have switched to the bicable technique, and I don't know that there's been any significant limitations with that.
Excellent question. Thank you. Other questions? Dr. Woodard.
Great job, Maedha. Question about like the consent process, I guess. So do you know, like, is it a different process for like the DCD organs relative to DBD?
Yeah, so I do admit I have very limited experience as being a resident, but I think just anecdotally, I feel like when we present the patient at transplant conference, they do say like, okay, this patient did have an arrest. I don't understand like how much the patient understands of like what that means for them, but they do disclose the fact that the patient has arrested before, but that their heart is acceptable. Yeah. But I do wonder how that relates to the kidney world, because I know that DCD, like kidney transplants are pretty common.
Yeah, and I admit I do not participate in that process, but I would imagine that is a disclosed
Yeah, but I don't know how much the patients understand. I think heart transplant in general is quite
Yeah.
nebulous.
Dr. Begur taught me everything that I know about DCD. I did not know anything about it. Dr. Rosen.
Were you surprised by how few arrhythmias there were in the two groups?
Yeah, I think the literature, like the documented literature shows incidences between 10 to 20% of sinus node dysfunction. So we're really expecting to have a higher number. However, I think the last published article on sinus node dysfunction after orthotopic heart transplant was like in 2012. And the adoption of bicable technique really happened around then. So I think it's very interesting that that kind of eliminated the problem.
Question.
Sorry, this is a very easy question.
I don't know if you think it's okay.
I'm just curious, for both the bicable and the bilateral techniques, you're cutting through some amount of inhale, like,
Yeah.
why don't we just cut the vessels off? That's such a messy question, but.
No, sorry, I didn't. What did you say the last part? Why don't you just do cut? Yeah. Yeah, so the bicable technique does limit how much of the heart you do have to cut. But at the same time, I think they do need to reattach the like aorta and the vena cava. So they do need to like attach the points of connection. So I don't know why they don't. I'm not a surgeon, honestly. Like I don't know why they don't do like a little sippy, but yeah, like the amount of heart affected by the bicable technique is really just like the top of the atria. So it shouldn't be too much. I don't know what the picture showed, but yeah, it's just like literally the top of the atria, right where the IVC and like the pulmonary veins are at. Yeah.
There may be technical limitations that we as internal medicine.
Yeah, I don't know. That's a great question. I just don't know the answer.
Dr. Begur, Dr. Timmer, thank you both for being here.
Please come next week for Department of Medicine Grand Rounds.